falling. No one witnessed the fall. And then she was confused after some of the episodes. This was ongoing for like 2 to 3 months before all this happened.
No, I'm gonna hurt that. Yeah, it's getting
So I think a repeat study at some point.
Thursday.
We haven't seen it, but when
I'm so suspicious of this, her case and her family. I mean, obviously she has this genetic condition that causes ataxia, and she has an abnormal MRI.
She was a genetic test so many times, I really had to like go first.
She's 10 children. She has
Oh,
pain,
I know.
she's addicted to painkillers. Her husband does something funny, so I don't know what's going on.
That's just one thing I was trying to explore with the husband, like was she taking benzos, was she taking points?
She does take benzos. She's on both
Clonopin.
Ativan and Percocet.
You eat Jesus week?
So that's why I was thinking, because I was doing this too.
He's on call December 3rd. That's why I'm on call next. I'm on call 3 times in December.
2 weeks?
3 weekends.
Oh,
3 weekends?
oh, I'm on call that last.
Why?
It's the price of being pregnant. I can't take it later. Oh, so I'm doing New Year's.
I'm on call December, I think 16th weekend, 16th, 17th.
I'm on that weekend.
Oh, December's a good time to take it,
Yeah.
not January.
Why January is crazy?
Maria can Maria,
She's on December 2nd.
2nd and 3rd.
And who's on New Year's? That's what happened.
Just have like a holiday on Thanksgiving on that Thursday.
Of course.
No, we,
So like
Really?
what? I
No,
didn't know
That's
that,
not
like,
affect me, I'm on night float.
Thursdays, whoever's on call.
am I off
So
that
who's
day?
on call will be the one like working on the weekend.
I saw someone's name in the yellow. In that, so does that mean I'm off for SCU?
So, no, so it's like a hot Saturday and Sunday. So
It's like a
who's on?
weekend.
It's
No,
like
no,
who's
no,
on?
the Saturday, Sunday I'm on, but Thanksgiving is on
When is that?
Thursday. So Thursday.
Chinese on New Year.
I get each one of the juniors.
Yeah.
One
So
after the
when
other.
is Thanksgiving? November?
Until Thursday.
I'm gonna give it like 2 more minutes.
So Thanksgiving, it's like a weekend, it's just one resident and one.
And then Friday is a regular day.
It doesn't affect me, I'm on night float. Well, you guys stay till 8:30 though, right?
Someone is working on.
Does that mean I'm off in the ICU?
Yeah, whoever is.
Living in Jersey?
So she will cover like she will work. At the weekend.
Overwrite it before we miss it.
Who's the second person who's on for Thanksgiving? Is it medicine?
Usually she do like that. Sometimes the ED doesn't get off. Those days.
There's no ED.
There's no reason for this one.
I'm alone.
Sometimes the holiday falls on the day when the ED is still here, they usually don't get off. We could be working on that.
Where's Joe and Anusha?
Anusha
Joe's
is
on
like
night
that.
float, Nisha's like.
Okay, so they're not coming, and then there's
Yeah.
some.
Summer and Maria should still be there. She's on vacation. There's not a lot of people here this month.
This is really not for residents, 'cause it's a little bit technical.
Maria's on her way. So Simone's still around. Is that her right there? Yeah, that's her. Simone's here.
Hey, we're waiting for you.
Hi.
Yeah,
How are you?
Yeah, it was.
Okay.
I think you can call it. Oh, I know. Everyone.
Okay, should we start?
Yeah.
Maria's on the way. Maria should be here.
Hi.
How you doing?
Alright, everyone's here.
Oh, Mariana.
I'm here.
All right, guys, so for those who don't know me, I'm Dr. Davia, I think most have met. I'm gonna give a two-part talk, so this is the first part of EMG Basics today. And this is a bit technical, and I think second and third year residents will have more familiarity. First year residents, it's something you just have to hear. It might seem kind of all over the place. Feel free to ask questions, but it'll kind of, it's good to hear it now, then you come down to the lab and rotate with us. You sink in some of the concepts, and as you read and do the cases, it'll become more common knowledge to you. So I'll just do like a brief introduction here. So what is electromyography? So as you know, we do, down in the lab, we do nerve conduction studies and EMG. Two go together. Today I'm going to focus on the EMG portion of it, and that itself is a two-part talk. The needle EMG portion is individualized based on the differential diagnosis. So I always ask the residents and students, if you're sending a patient down, what are you looking for? That's going to help us determine how we do the study. It's important to select the top priority muscles in case you do the first needle and the patient's intolerant completely of the needle study. You want to go for the money with that first. We do that especially in children. We go for the weaker muscles to see if we can get that diagnosis right away. The choice of muscles also depends on what you see on the exam and what you've already found on the nerve conduction study, which is the first part of the test. Always be sensitive and consider the patient's discomfort and awareness of some muscles being more painful than others. And just remember, this is something that takes time to understand and absorb, not in only concept, but in practice and technique. And it takes that much time to master the recognition of uncommon and more subtle needle EMG findings. So here's what the equipment looks like. So there's a variety of companies that make EMG machines. We use the Viking, which has actually now joined with Synergy. So our newer machines, which we're slowly taking out of their cases, have a combined program of both the Synergy and the Viking. I trained on the Cadwell, which I find very user-friendly, but everyone has different preferences. There's two types of needles. There's the monopolar and the bipolar. Here at Einstein, we use the bipolar or concentric needles. As a supply, in addition to the needle, you need a cable to attach it to. So that's this cable, and we attach this needle tip right here. You'll need a ground electrode, which tunes out all of the other electrical artifact in the room, and that's stuck to the patient. And you, of course, need gloves. And here's what a typical EMG software looks like. So concentric versus monopolar needle. So what we're doing is whenever we're measuring a potential, we're measuring it in reference to something else nearby. So in every EMG study, you need an active recording electrode and you need a reference electrode when you're measuring the potential between them. So that's how you measure the voltage between active and reference. So a concentric needle, out of convenience, has both the active and reference in the needle shaft. So the shaft is the reference and a small wire through it is the recording needle. In contrast, the monopolar needle is only the active recording, and then you have to attach a surface electrode as a reference. So there's pros and cons to both. Here's kind of an example of what your recording field with a concentric needle, which is what we use. So here you have a tipped bevel, and you're basically covering a radius outside of it in a teardrop configuration. The concentric needle is when you look at the motor units, they're slightly smaller in amplitude, and that's just something you get comfortable with your eye looking at if you're using one or the other. And the benefit is that you don't need that extra surface electrode. And every time you have an extra surface electrode, you can move it around every time you switch the location. Whereas a monopolar needle, it's smaller, it's a little bit more tolerable, but you require that extra surface electrode. And sometimes you get more artifact because a surface electrode is much farther than a reference that's right in the shaft. Make sense? So how we go through the procedure, we explain the EMG, kind of walk them through what they're going to experience and kind of try to temper their fears. You select muscles and locate them by using anatomic landmarks. It's always nice to demonstrate to the patient how to activate the muscle before we get started. Sometimes I just tell the patient, try to relax, and I'll tell you what to do, and I'll slowly have them activate once the needle is in. Once the needle is in, you can have them quickly activate to make sure you're in the right place. Once you've done it so much, we know, like, you know, a deltoid is pretty obvious, or a bicep, but sometimes if you're going into the intrinsic hand muscles, you activate to make sure you're in the right place. And then what we're doing is we're assessing for insertional activity and spontaneous activity, which is what the bulk of today's talk is about. These are just some settings. So the sweep speed is how much you're seeing on the screen. So we do 10 milliseconds per division. So you'll see 10 divisions on the screen. Each of those is 10 milliseconds. The sensitivity is basically you're setting it so that you can see them at the best size and visual appearance. So if you reduce the sensitivity, they're going to look much smaller. If you go, they're going to look much bigger. If you go higher on the sensitivity, they're going to go much smaller. So when you're looking at the potentials at rest, you want a low sensitivity because you're magnifying very small amplitudes.
That's when you're seeing
versus-
like large amplitude kind of things.
Well,
You
that's
go
when you're
higher.
looking, when you're
So you
recruiting,
can-
you're going to see all this voluntary muscle. So you have to
So you-
increase the sensitivity.
Right, so they can fit it.
So you can see it all in one screen. Yeah. And the conventions are good. So the idea is if we all do it at 50 and we all do it 10 milliseconds, we all have the same visual of what these happen. So then we assess motor unit action potential. So you keep the sweep speed at 10, increase the sensitivity to 200. I personally go higher to 500. And that's what my eye is just trained for. I think Dr. Zhang and the others do 200, and that they might go up to 500. And then you gently ask them to contract, and you'll see all these voluntary muscle motor units coming through. You assess the amplitude, duration, phases, all kinds of analysis at that moment to determine an abnormal or normal pattern. And then you proceed to the next muscle. So all of this takes very little time, but it sounds lengthy, but how fast do we do it, right? It goes super fast. And that's because of experience and that trained ear and eye. So things to remember, inserting the needle into a contracted muscle is much more painful. So you want to make sure you've identified your landmark, then have them relax, then place the needle. I don't think that's always true, especially if patients aren't tolerating it very well. Sometimes I'll say activate it, place the needle quickly, listen to that quick reactivity, and then I'll pull the needle just under the surface of the skin, not all the way out, and have them relax and they tolerate it. So there are some variations to this.
Is that to help identify the muscle?
Yes, or just quickly get my recruitment pattern if that's what I'm interested in more than anything else, to see if it's neurogenic or myopathic. Do not proceed with insertions until you're certain you're in the correct muscle. We talked about that. Most spontaneous discharges are of low amplitude and may be missed unless you keep that sensitivity low. Okay, we made that point. And in every muscle insertion, there's going to be a brief burst of muscle fiber potentials that are very short. They last less than 300 milliseconds after the needle has stopped moving. And that's what we call insertional activity. That can often be confused with abnormal spontaneous activity, and we're going to talk about that. So once insertional and spontaneous activities are characterized and the motor unit action potentials are observed, you can determine what the pattern of abnormalities is. You can also, this is kind of pointing to what can an EMG tell you? So it can localize, it can tell you severity, whether something is acute or chronic, and it can tell you the difference between a neurogenic insult or a myopathic insult. That being said, it's still a very limited study, as you may know, especially when patients have multiple things going on. For example, if they have a severe diabetic neuropathy, and then they're coming with new radicular symptoms, it's very hard to tell what's what. So there are limitations to the study. But EMG findings, along with the nerve conduction studies and the clinical picture, which is very important, allow us to finally give an electrical diagnosis. So spontaneous activity. So recognition of spontaneous activity is one of the most important parts of the needle EMG. That's often what we're looking for. One important point for residents, because you're sending patients from the inpatient setting, spontaneous activity takes 21 days usually to occur. So you're often not going to see it unless the symptoms have been going on for several weeks. The distribution of spontaneous activity localizes the lesion. The type of spontaneous activity can give you an idea of the pathology, whether or not it's coming from the myofiber, which is happening. Whether it's coming from the myofiber, the axon, or motor unit itself. It can tell you the degree of activity, which can determine severity. And it can also help with the time course based on what you're seeing and what you're not seeing. Okay, so these are some examples of spontaneous activity. So I'm going to go over this. This is just a visual, but end plate spike, positive sharp wave, fibrillation, I'm missing an L there, fasciculation, neuromyotonic discharges, and myokinic discharges. Does anyone have any familiarity with any of these discharges or any thoughts? So what's an end plate spike?
When
Normal
you're
muscle.
Where is that discharge coming from?
from the junction between
Neuromuscular junction. So it's basically spontaneous depolarizations at the neuromuscular junction, which are normal, that by placing your needle in that wrong spot, you're picking up. The importance of recognizing this is differentiating it from these. You can see they somehow look a little bit similar, especially fibrillation potentials. The key is that this is very painful. So if you go in and you see end plate spike, they'll have a lot of pain, and you quickly move the needle and it goes away. There's also an additional end plate sound that I think I have a video of. I'll show you guys later. Positive sharp waves are also spontaneous activity. Let me kind of reverse for a second in case spontaneous. What is spontaneous activity?
Membrane is discharging.
Right. So do they fire regularly or irregularly?
It should be regular. The abnormal one should be right.
Abnormal spontaneous activity when we're talking about positive sharp waves and fibrillations are usually irregular.
Because when we see the fibers like
It's very erratic. Sometimes when the patient's not completely relaxed, you get voluntary motor units. And the way to tell the difference is those are very regular because it's kind of the patient's voluntarily doing it with the same force. Whereas these are spontaneous discharges from the muscle fiber cell, the myofiber. Okay. So positive sharp waves and fibrillations, we differentiate them, but they mean the same thing, and they come from the same generator, which is the myofiber. Okay. Fasciculations, on the other hand, where do those originate?
Yeah, the muscle, which is denervated, right?
It's from the motor unit. So it's from the axon and all of its myofibers. So whereas positive sharp waves and fibrillations are spontaneous from the cell, this is from the motor unit. And that's why it has this polyphasic appearance. That's the one way to remember it. One axon, multiple muscle fibers. Whereas these are individual muscle fibers. Neuromyotonic discharges we'll talk about a little bit later, but they're very high frequency. They're actually the highest frequency discharge you can get. It's this up spike, but also all these tiny spikes behind it. And then there's myokymia, which is more of a rhythmic interlocked discharge at the same frequency, which you can see in some condition. So these are generally the spontaneous discharges we're looking for. In a practical sense, we're almost exclusively looking for positive sharp waves and fibrillation potentials to tell us if there's an acute process going on. Questions on this? I'm going to kind of reiterate some of those points. But any questions so far?
How do you, like, it goes by so quickly. So how do you remember what shape it looks like? Because whenever I've seen it,
Most of it's
It
just
just
a
runs
sound,
over.
right? It's just
It's a sound and a
Yeah,
pattern, and it also
so
it shouldn't go away.
Yeah.
So when we put the needle in,
Mhm.
we don't take it out right away. We put it in and then we
Yeah.
advance it and we advance it. So
Mhm.
if there's true pathology, you don't just see it in one plane. You
Okay.
see it in multiple planes, and that's why we do that.
Mhm.
Is to really increase our yield of finding these potentials. So you might see it in one plane and then they kind of go away, but then you move it around to, and I do that because I'm not going to make a call on one spontaneous discharge.
Mhm.
I'm going to convince myself that it's there. So you keep moving it around and you continuously hear it. And a lot of the time, because remember, these are of the same pathology, they come together. So you see these deep deflections, but you also see these tiny upswing, tiny kind of narrow discharges that are fibrillations. So here's just another way of looking at it. So the motor neuron, so remember the axon and then all of its muscle fibers can generate fasciculations, myokymia, tetanic discharges, cramps, and neuromyotonia. The terminal end plate discharge comes from the junction, right? Neuromuscular junction. And then here at the level of the muscle fiber, you get fibrillations, positive sharp wave, and myotonia. And then we didn't talk about this yet, but I think I have a video. Complex repetitive discharges. We see them very non-specifically, but it's when there's the myofibers somehow link up together and fire in synchrony. So you see the individual discharges, but they're time locked. So you see them together and they have a very characteristic sound. It's like, yeah, exactly. This is obviously tiny. I think I'm going to jump instead of spending time on it and just do the pictures are better than words, right? Okay. So here are some pictures of what these spontaneous activities look like in another kind of based on the source generator, which we kind of talked about. So here's a miniature end plate potential. Here is a motor fiber action potential. So these are spontaneous depolarizations at the muscle fiber. These two are similar. They just have a little bit different morphology. This one is triphasic and this one is biphasic. These are B, C, and D are all kind of the same idea. They're sourced from the motor, the muscle cell or the myofiber. E is a CRD. So remember we said these are individual discharges from myofibers. Same as this, but they're all linked together. So they kind of travel in one. And then if you can appreciate, this is a big motor unit action potential, a voluntary motor unit. See how much bigger it is when you compare them? And that's what you don't want to mix up between. Okay, so when we're analyzing spontaneous activity, we're looking at all these different features. So the morphology, whether it's coming from the muscle fiber, if it has brief spikes, positive waves, if it's actually a motor unit or multiple muscle fibers, versus the stability of it. So a stable unit looks the same every time it comes through. An unstable unit may have polyphasic features. So and again, that picture speaks better than words, so I'll go on. Unstable units may have waxing and waning appearance. They might start and stop abruptly. That's what CRDs do, complex repetitive discharges. And then this is the most important part. What's the firing characteristics? So are they very slow, fast, or very fast? The very fast ones can help you characterize, because remember we said myokymia and neuromyotonia have a higher frequency. If they're slower, like fibrillations and positive sharp waves, that kind of puts you in a different category. So it's about knowing what abnormal spontaneous activity fires fast versus fires slow. And then the pattern of firing, is it irregular, regular, waxing and waning? Which one tends to wax and wane? So what are that you mean the end plate potentials? There's a specific spontaneous activity that tends to have a waxing and waning.
Myotonic dystrophy,
Myotonic discharge.
the one that sounds like a heavy.
The bomb.
Yeah, the
I
bomb
might show
bursting,
that
yeah.
case if you don't mind. We have a video. Okay. So firing characteristics. Sorry if this is getting a little rote. Just keep chiming in if you guys have any familiar cases that you remember these words from. But so we look at the discharge pattern and firing rate, whether it's regular or irregular, if there are fibrillation potentials and positive sharp waves, and you want to note that they're regular. I'm sorry, regular versus irregular. Complex repetitive discharges, which tend to be perfectly regular because remember, they're time locked. And if they're irregular, are they sputtering, which is what you hear in end plate, waxing and waning, which you hear in myotonic discharges, waning alone in neuromyotonic discharges, and bursting pattern, which tetany and myokimic discharges, but also just simple cramps that people get. Sometimes they'll hear this spontaneous, really loud, high frequency sound, and then it goes away and it correlates with cramping. Okay, so all spontaneous activity is abnormal. Get that in your head for your boards. except for one, the end plate. And so when you hear that characteristic end plate sound, first thing you want to do, move the needle. Exactly. Those are tend to center in the belly of the muscle. Patients perceive a deep pain, unpleasant sensation. There's end plate noise and end plate spikes. It's really important to notice these. And this is another good point to your question, Suman. End plate noise will go away once you move the needle. Spontaneous activity should be present, even if you, like abnormal spontaneous activity should be present, even if you take the needle away and move it to a different area. End plate spikes fire irregularly and are seen with end plate noise. So here's this was from YouTube, I think. Is the sound working?
It's on. The light is on.
It's on.
There's a light. There's a light.
Oh, here, this is really low. I'll play it again. So they're just, so first of all, you hear that seashell sound, it's very staticky. That's one sign that you're in the end plate. And the other is these irregular, they're very narrow, high spike time. Those are end plate potentials. They look very different than fibrillations, which tend to be much smaller and more regular. So it's a very ugly, staticky sound when you're in the end plate. So insertional activity is also normal. So insertional activity is when you first place the needle, everyone's going to hear a sound. That's how you know you're in the muscle. But it goes away very quickly after 300 milliseconds. And that's how you know you're in the muscle. It's the needle movement resulting in a waveform that lasts longer than 300 milliseconds that suggests of an increased insertional activity. So sometimes we make a note in our EMG table that there was no spontaneous activity, but there was increased insertional activity. And it might be a sign of something non-specific going on, but there's some irritability that it's not clearly pathologic yet. So yeah, increased insertional activity can be seen in both neuropathic and myopathic conditions. And when you have a very diseased muscle, very weak or atrophied, and you get in there, sometimes you don't hear much at all, and that's a sign of sclerosis or fibrosis, fatty replacement of the muscle. Okay, so sometimes I comment, if there's a clinical correlation of weakness or a foot drop, and I don't hear much in that muscle, I'll say there is reduced insertional activity. Okay, so we're going into the abnormal. Are you guys still with me? The abnormal spontaneous activity. So fibrillation potentials, they're derived from the extracellular recording of a single muscle fiber. It's a spontaneous depolarization of the muscle fiber and a marker of active denervation. Typically, you see it with neuropathic disorders, but sometimes you can see it with myopathic disorders. So which neuropathic disorders can you feel it? Yeah, so acute radiculopathy. What else? Yeah, I mean, anything that causes the nerve ending to die back from the muscles. So any acute peripheral nerve pathology. So even in carpal tunnel, if it's bad enough, or if there's enough axonal damage and that nerve is dying back from the muscle, you can see spontaneous activity. Or something as severe as ALS. Rarely you see it in severe neuromuscular junction disorders like botulism. The morphology is a brief spike with initial positive deflection and a low amplitude. There's a regular firing pattern of 0.5 to 10 hertz, and it sounds like rain on a roof. It actually sounds like rain on a tin roof. It's like a very pitter-patter sound. And I think this is a video. So you hear that coming through? Very regular. Or, sorry, irregular. This sounds regular though. There should be more. So here, this is the fibrillation. This is actually what?
Shortwave?
Correct. And they, like I said, they often come together. And now you can hear the irregular nature of this. You hear how it's not consistent. Okay. You want to hear it again? Or are you good?
Let's hear it once more. It's different.
Remember 50 sensitivity. So here it's just fibrillation. Stops. You move your needle, that's what that sound is. Now you see a little bit more. And it's firing a bit faster with positive sharp waves. So again, we talked about positive sharp waves, same significance as a fibrillation. There's a brief initial positivity. That's the downward phase, followed by a long negative phase. It's a dull popping sound, firing pattern similar to fibrillations, 0.5 to 10 hertz. You have to differentiate these from voluntary motor units at a distance. So sometimes your needle will pick up motor activity from a distant muscle, and it'll look, because it's far away, it'll have that downward deflection. And that's something you have to, and the way you distinguish it is because of the firing pattern. And we do this arbitrary grading scale where we say +1, +2, +3, +4, and no one actually follows any official cutoffs for what makes it 1+. It's basically, if you see just a few and they go away, you call it 1. If it's a little bit more persistent, it's 2. It's a little bit more, if it's, every needle plane, 3. And then if you see it filling up the whole screen, then you consider it 4+. So CRDs, complex repetitive discharges, are a depolarization of a single muscle fiber, followed by ephaptic spread, that means adjacent spread, to denervated fibers. They're time-linked spikes, high frequency, repetitive discharges. Here's the key, they have an abrupt onset and termination. So these often get confused with what other discharges? Anyone?
Voluntary activity would look.
Not really, because you have this broad discharge of multiple myofibers. In motor units, they look much larger and broader.
Myocardial.
More myotonic discharges, but the difference is myotonic discharges have that waxing and waning sound. These have a very abrupt, they come and go and they sound exactly the same. It's the same, it doesn't change. But it doesn't have like loud. Steven's laughing. So in between, that's the needle moving. You hear that's just the needle moving around. That's the examiner looking for it again. So needle's moving. It's all quiet in between. Here you go. Comes on. See how they're all the same? And each one represents different muscle fibers. They're all just linked together. It's a fun one. It actually has very little meaning in the lab, but if we put it together in the clinical context. So young people that are really healthy generally don't have these, but diabetics, we see them in muscles, but it doesn't have a definition in terms of denervation. See here, it says, occurs late in disease where there's reinnervation, fiber type grouping, or subsequent denervation. So it's very non-specific. Okay, so spontaneous discharges of muscle fibers. The myotonic discharges are spontaneous discharges of the muscle fiber as well, but they're different, again, in characteristic because they have this waxing and waning amplitude and frequency. And the firing rate, look how much faster. Remember, fibrillations, we said 0.5 to 10. These are 20 to 150, so much higher frequency. You see them in a variety of conditions, usually channelopathies, so myotonic dystrophy, myotonia congenita, paramyotonia congenita, and certain myopathies. It has the sound of a revving engine. So revving is like the waxing and waning, crescendo, decrescendo sound. So here you'll notice the difference. So remember those complex repetitive discharges we just talked about and compare them here. You get a difference? Hmm? Let's go again. Oh, I think they're going to show it in a different mode here. Okay, you can hear the difference between that and the CRD. I want to save time for a quick case, so I think we're almost done. So switching gears to fasciculation potential. So these are abnormal motor unit potentials. Got that? So single spontaneous involuntary discharge of an individual motor unit. So an axon and all of its muscle fibers. They discharge together spontaneously. They are very slow and irregular, usually less than 1 to 2 hertz. So the key there is that if you are looking for it, you have to be patient. And it's the same thing clinically, right? When you're looking for fasciculations in a patient you're worried has ALS, you're going to stare at their muscles for a good 20, 30 seconds each. The source is the motor neuron and its axon. The morphology is of a simple motor unit or more complex and large reinnervation. So that's because sometimes when it's damaged enough, it's had collateral sprouting. So the axons have reinnervated neighboring motor neurons, and so the discharge becomes broader and larger with time. So it's associated with numerous disease processes affecting the lower motor neuron. You can also see it with benign fasciculation. It has a characteristic corn popping sound, dull, and you need to give it time to hear it. See them? They're like pop up. They're very random. Some of them are monophasic. Some of them have more polyphasic. They're longer. And it sounds like popcorn popping, right? So contrast these to positive sharp waves, which are more frequent, right? You see them more continuously throughout the study here.
And they're not polymorphic.
They're not polyphasic, exactly, which differentiates the source.
It sounds really like dull and
Very dull.
it's like slow.
It's like bum,
Yeah.
bum. It's kind of random. Okay. Myokimic discharges, we don't see these that often, but when you do, it has a very characteristic sound. So these are rhythmic, group spontaneous discharges of the motor unit, similar to fasciculations, but they're much more frequent, 5 to 60 hertz. They have a marching sound. If you slow down the speed on the screen, you might be able to see the bursting pattern. So if you have it at 10 milliseconds, it might look much broader, but if you increase, so you slow down the sweep speed means you increase the time for each increment, you might see things shrink and you can see the onset and the ending. Clinically, it's recognized as involuntary quivering or rippling or an undulating movement. And the characteristic, this might show up on the neuro board, is that it's very classically seen with radiation. I've seen it maybe once or twice. So you see that? That whole thing is the discharge.
What is this?
This is where you see it, you see more time on the screen. See how it's more marching and they all come together. All right. This usually you look for when the neurologist has the history of the radiation, or there's a radiculopathy that without any clear changes on the imaging, you don't think it's structural. That's when you start getting suspicious. Okay, and cramp discharges are painful involuntary contraction of the muscle that occurs when the muscle is in a shortened position and contracting further. They are high frequency discharge of the motor axon. They fire very fast, 4 to 75. They can be benign. We all have experienced cramps probably, or associated with neuropathic or metabolic conditions. The key here is, this is what voluntary contraction looks like, but you see the patient, they're not voluntary contracting, they're probably stuck in a cramped position, and that's how you can tell. It's a normal firing of the Lastly, neuromyotonic discharges are the highest frequency, 150 to 250 hertz. They have a decrementing repetitive discharge of a single motor unit. There's a pinging sound. I actually have maybe seen one case of this in residency, but they're the highest frequency of any discharges. They represent the end of spectrum of abnormal spontaneous activity generated from the motor nerve or from the motor unit. And you can also see it in chronic neuropathic conditions like post-polio syndrome. That's what that sounds like. I think this was the only video I could find. But do you see how it's just waiting? It sound. It's not. It doesn't have myotonic sound up and down, and it's very fast. And just a kind of a clinical correlation of neuromyotonic discharges, the most clearly identified one is called Isaac syndrome or acquired neuromyotonia. It's an autoimmune channelopathy, so patients may get it in their 20s and 30s. It's not a childhood condition. The antigen is a peripheral nerve voltage gated potassium channel. The target is an antigen. The target antigen is a peripheral nerve voltage gated potassium channel. Clinically, people have stiffness, hyperhidrosis, and delayed muscle reaction. So as a summary, insertional activity is normal, spontaneous activity is abnormal except for the end plate. Fibrillation potentials and positive sharp waves are the markers of active denervation, but again, you can see them in acute myopathy as well. Neuromyotonic discharges are the highest frequency, and myotonic discharges have a higher firing rate than fibrillations and positive sharp waves, and that's how you differentiate them. These are the kinds of things that are more often on a neuromuscular board, but they might just try to get you on the neuro board with differentiating, especially the more characteristic myotonic discharge. You know, they have, when you took the right exam, was it all on computer or written? Written. Okay, so on the board, you're going to have live video, and they'll just play something. Either it'll be a patient's gait, and they ask you a question about their gait, or they'll show you something like this. Usually it's the more common stuff, like a repetitive stimulation showing the decrement. But you may get myotonic dystrophy on that. It has such a characteristic waxing waning. So they'll show you the video, you'll hear that sound, and then they'll ask you a question, like a case vignette, about like, is the patient most likely to have testicular atrophy, cataracts, blah, blah, blah. And you have to know myotonic dystrophy is associated with cataracts. But they get you with, you have to recognize it first on the EMG. Does that make sense? Yeah. So do we have time for a quick case? It's on my iPad. Yeah. No, so. Okay, so I had a guy, and this is, I just thought I'd share it because it has some relevance to what we talked about. He came in like a month ago to my office.
Yes.
1 month ago, healthy guy, 30 years old, African American, and he, his chief complaint was my hands feel weak. So no pain, no paresthesias, nothing else, just my hands feel weak. So of course I asked other questions. neck pain? Have you been dropping things, you know, like what you would ask for carpal tunnel, nocturnal paresthesias, none of that. And then when we examined him, any other questions you would want to know? Pertinent questions based on that history?
Symmetric.
Symmetric, yep.
Is there any atrophy?
So I'll show you his exam. But he had no trouble climbing stairs, no weakness with his gait. He doesn't fall. He has nothing else.
No family history?
No diabetes, no family history. Sorry, these are intermixed. No history of trauma. Where is it?
It was like a pure motor kind of complaint.
Complaint, yeah, no pain, no paresthesias, just weakness in the hands. No trouble combing his hair, no abnormal movements.
Progressive or like?
He couldn't really tell. He
Sam, you wanna
said,
come
he
here?
said it's been going on for 5 years, so chronic. That's for sure. Sorry that it's not a bigger picture. If we had airplay, I could. Right. So I can show it a couple times and bring it closer to you.
Oh, thank you.
So this was me in the clinic, just getting some features of his exam.
Toward the camera and smile, good. And then you can look toward the camera again. Close your eyes real tight, tighter than that. It's like they're soaking
Yeah.
up. And then you can see that I can open them a little bit. Can you raise your eyebrows? Okay. All right, put your arms up nice and strong here. Good, deltoids are strong. Pick a muscle like that. Push me away hard as you can. Good, and pull towards you. Same thing here. Good, pull towards you. Put your hands strong like that. Okay, go, let me push them down. Curl them in. Here I can completely overcome. Curl them in again, real strong. Finger flexion is very weak. Curl it up again. Let's demonstrate that again. And the same thing on this side. Curl your fingers in. Those can be overcome.
The finger, like the
Keep your
radius.
wrist, your finger straight like that. That's pretty strong. Bring your wrist up like that. That's very strong. So we're just seeing weakness of curl the fingers in, just finger flexion here. Okay, so I'm just going to show the reflexes here. A little depressed.
They're not the most
And
exciting.
I'm also going to tap. If you can come closer here. Let's do this here. And if you come real close, you can see that there's a muscle contraction there before it completely relaxes.
You guys see that
Let's do it again. Here, just try to relax.
See it? Indented.
See that? Let's try it on this side. Relax. Come close on that muscle, yeah. Relax. Do you feel it? Okay, so we're just gonna tap here.
What is that?
And then it slowly relaxes afterward. Let's try the other hand.
He had a little ptosis and frontal bone, and he had difficulty relaxing his hands, and he had some mild difficulty with feeling to walk.
But no family history.
Did you see them? I told him to go home and talk to his mom.
Let's try this one more time.
He said no.
Come
He's
over
not
on this side.
adopted.
Yep. You see the muscle looks relaxed.
Okay, do you have
Contracts.
The face is like.
Okay.
He had kind of a long face.
Yeah.
He was bald. At
I saw that in
30,
the
he
video.
had frontal balding and mild eye. And if you look at his smile, guys, look at his smile.
Okay,
Most
so I'm
people
just
have
gonna
a.
examine your face. Can you smile for me? Toward the
These are
camera.
the things you
Smile.
want to do
Good.
in
And
the
then you can look toward the camera again. Close your eyes real tight. Tighter than that. It's like they're soaking up. And then you can see that I can open
So
them a little
the,
bit. Can you
the
raise
point
your
I want
eyebrows?
to hit home is this guy came in with
Okay.
such mild findings.
Put your arms up nice and
Judgment,
strong
and
here.
hardly any complaint.
Good.
But
Deltoids
it's
are
up to
strong.
us to look.
Take a
Why,
muscle
you
like
know,
that.
what else could
Pushing
be
you away
going
hard
on
as you
with this
can.
child
Good. And
together?
pull towards you.
Otherwise, I had no
Same thing here.
localization for isolated finger
Good. Pull
findings.
towards you. Put your hands strong like that.
Localizing for the muscle.
Let me push them down.
Alright, so- Actually, I might have it. You sent it to me,
I
didn't
think I
you?
sent it to you.
On WhatsApp. I don't have WhatsApp. So this is when we put the needle in his muscle.
That's neuromyotonia.
The same as myotonic.
But it's not
dysfunction.
waxing and waning.
Neuromyotonia is waning only.
Yeah. Okay.
This is.
Oh.
We have a lot. We did multiple nurses. This is recruitment, so I'm asking him to volunteer.
That was his school recruitment?
That's full recruitment. It's kind of fast, so I think it's myopathic actually. Early recruitment. You've got.
I think it's more like information coming.
This is recruitment?
No, this one was controversial.
You hear it?
Mm-hmm.
That's all motor units coming through because he's not relaxing. It's very fast.
This
That's
one.
it.
We'll start binging.
Like a Mongol. It's music. So that was a good case. Philip got to see it in the lab.
Look at